So I'll be talking on the role of Angio-CT for selective internal radiation therapy, or SIRT. So what SIRT is essentially is the selective delivery of yttrium-90 labeled microspheres via the hepatic artery into the liver tumor. For SIRT to be effective and safe, we need to deliver a high radiation dose to the tumor, minimize the amount of dose to normal liver, and try to avoid any extrahepatic deposition of the microspheres. So there are two commercially available types of yttrium-90 microspheres on the market. Over here at SGH, we use the resin microspheres, which has more spheres per treatment and slightly lower radioactivity compared to the competitor. So the main clinical indications for Y90 at our institution is mainly in palliative treatment of unresectable hepatocellular carcinoma. Sometimes these patients are downstage sufficiently so that they can undergo curative treatment. Other tumors are much rarer, but colorectal liver metastases are probably the second most common tumors that we treat with Y90. So HCC needs no introduction to this region. It's a very common cancer in this region. Not many patients are eligible for curative treatment at time of diagnosis, and if you don't offer them any treatment, their overall survival is usually quite poor. So while it's not formally incorporated into the BCLC treatment algorithm for HCC, it's generally accepted that SIRT has a place, has a role in treatment of patients at the intermediate stage B and advanced stage C HCCs. So once a patient has been diagnosed with HCC on CT or MRI, they'll usually undergo some laboratory testing to check their liver function tests, coagulation profile, and assess their performance status. All that information will then be put forward before a tumor board, which will make a decision whether or not to offer the patient Y90. And if that is indeed the case, to proceed with Y90, then the patient will come for a two-stage procedure. The first stage of Y90 is essentially vessel mapping, where we try to outline the hepatic arterial anatomy. And this is where intra-arterial CT plays a key role, alongside the technetium-99 macroaggregate albumin SPECT CT. And then once all that is done and patients deemed suitable for Y90, then the second stage of treatment is where the Y90 is actually delivered with or without some embolization, which I'll come to in a minute. So it's very important to realize that SIRT is performed differently to TACE. To perform SIRT, you need to carefully plan your procedures. You need to understand the various types of anastomosis that occur in the liver in order to deliver an accurate dose, an effective dose for treatment success, and to reduce the risk of complications. And to achieve that, we also work very closely with our nuclear medicine colleagues. At SGH, we are very fortunate to have the hybrid Angio-CT system, which is an invaluable tool when performing these Y90 cases, as it allows us to perform high-quality catheter-directed intra-arterial CT angiography. So as the previous speakers have alluded, essentially what the Angio-CT system is a room that houses both the CT scanner and the angio system, and the patient lies on top of a shared floating tabletop that can move in and out. And essentially, with the Angio-CT system, you save time without having to transfer the patient to the CT scanner and back. So you're talking about 5 to 10 minutes compared to 45 minutes to an hour if you need to transfer the patient out. So I hope in the next few minutes I'll convince you why we need to do intra-arterial CT for our Y90 cases. I think of three main advantages. The first being anatomy. So a lot of these tumors that we treat are quite large, and when we do Y90, we want to make sure that we deliver Y90 to almost all of the tumor. Secondly is safety. We want to avoid some of the hazardous branches that come off the hepatic arteries and avoid any extrahepatic deposition of Y90. We need to make a decision whether or not we need to protect some branches by embolization. And sometimes patients may have borderline liver function, and you might want to spare the non-affected liver portions. And last but not least, the intra-arterial CT is very important in dosimetry calculations for Y90. So you've seen this slide from the earlier speakers. Essentially, to do the intra-arterial CT, you first do a regular hepatic angiogram from your microcatheter, and then you connect your microcatheter to the CT injector pump, move the C-arm out of the way, and then the CT gantry into position. Review your DSA images to decide when is the peak tumoral enhancement, to decide your scan delay and control injection parameters, and then proceed to do the CT scan, either in single or multiple phases. So we know the hepatic arterial anatomy is very challenging. A large number of variations have been reported in the literature, as you can see here on the right. As it's quite variable, it can be quite challenging to a slightly less experienced interventionalist. In addition, if the patient has had previous resection or embolization, that can alter the anatomy by quite a fair bit. And quite a lot of the tumors that we treat are quite large, so sometimes these can parasitize blood supply from adjacent organs. This is an example of a patient with multifocal HCC. Here is a celiac angiogram showing the gastrohepatic trunk, middle hepatic artery, and right hepatic arteries. We went on to interrogate the middle hepatic artery, which shows some enhancing tumors in the left lobe. But a less experienced interventionist might not pick up this right gastric artery at the time. But we did an intra-arterial CT, which very elegantly demonstrates enhancing tumor in the left lobe, but also gastric antrum enhancement. So with this IACT, we know that we'll have to coil off this right gastric artery, which was done prior to yttrium 90 delivery, which you can see in this last image here. This is another example, again, of a patient with multifocal HCC, left hepatic angiogram, showing some enhancing tumors in the left lobe. On first glance, we don't definitely see any extrahepatic branch, but when we did the ICT, very clearly shows there's gastric enhancement, and when we looked more closely at the initial angiograms, we could see the accessory left gastric artery coming off the left hepatic artery. And when we cannulated this branch and did the angiogram, it showed a nice draining coronary vein. And of course, this branch needed to be embolized before delivering the yttrium 90. Repeated the ICT in this case, and it very confidently tells us that yttrium 90 won't go to the stomach, but will be deposited in the tumor, only in the tumor. The previous speaker has also mentioned that now we can do virtual roadmaps from the IACT, such as in this patient who has a small tumor in the left lobe. On DSA also has a gastrohepatic trunk. Not easy to identify the enhancing tumor, and as well which branch you need to go and cannulate. But once we did the intra-arterial CT, as you see here on the bottom right, it will show obviously the gastric enhancement and also the enhancing tumors in segment 2. With that ICT, you can pick out the tumor and as well identify which is the feeding tumoral branch, as well as the best projection that you want to cannulate that branch. This obviously is an excellent feature that allows you to save fluoro time and contrast, which would benefit the procedures and the patient as well. So as I mentioned earlier, some of the tumors can be quite large and parasitize blood supplies from various arteries. This is a long list that has been reported in the literature, and I'll show some examples of this. Over here we have a patient with a very large tumor, HCC in the right lobe. On first glance at the right hepatic angiogram, one might be slightly misled into thinking that almost all the tumor is covered from injection in this position. But when you look at the intra-arterial CT, it clearly demonstrates non-enhancing portions posteriorly. And we subsequently hunted for other parasitized vessels, and here was the right inferior phrenic artery, which shows on ICT the previously non-enhancing portions. So In this case, we coil embolize the diaphragmatic branches to protect the diaphragm, and then safely delivered yttrium-90 into the right inferior phrenic artery. Another case of parasitization, this time from the right kidney upper pole artery. You can see on the non-selective angiogram, enhancing right kidney upper pole. An abnormal branch here that's tortuous with irregular vessels, possibly tumor, possibly not, but on IACT, very clearly again it shows that these abnormal vessels do indeed represent enhancing portions of the tumor, which otherwise might have been missed if only the right hepatic artery was treated. So in this case, we decided to do bland embolization of this right upper pole branch to allow redistribution and subsequent Y90 delivery into the hepatic arteries. So IACT is also very important to perform Y90 safely. We want to avoid, as I mentioned earlier, non-target embolization, because if yttrium-90 ends up in the stomach or duodenum, it can cause very, very horrible ulcers. As in this case, patients can be symptomatic for quite long and may even need further treatments such as surgery to resolve that. So we want to avoid that if at all possible in all our patients. The falciform artery, over time we've become more confident and doing less embolization of the falciform artery, but again, if Y90 is deposited, it can cause some radiation dermatitis over the anterior abdominal wall. This is an example of the falciform artery. Again, this is a left hepatic artery angiogram, not showing any definite signs of the falciform artery at this point. We did the IACT. Clearly shows multifocal tumor in the left lobe. When we evaluated the IACT in the coronal, in the sagittal plane, we can clearly see there's an artery running towards the abdominal wall, which is the falciform artery. We redid the left hepatic angiogram in another plane, which clearly demonstrates the falciform artery now. When we injected the MAA was deposited in the falciform artery and the anterior abdominal wall. Of course, in this case, we embolized it with coils, and Y90 was again safely delivered. Is prophylactic coil embolization required in Y90? I think previous guidelines back in 2006 had recommended that extensive prophylactic coiling should be done to prevent extrahepatic deposition. But a more recent systematic review in 2016 showed that there's really no evidence that embolization, excessive and extensive prophylactic embolization will reduce your complication rate. We've had that belief for many years now, and our embolization rates are below that of the literature, lesser than 20% approximately, compared to about 40% in the literature. IACT is also very important for Y90 dosimetry. There are various methods for calculating dosimetry in the literature, but over at SGH we use the artery-specific SPECT-CT partition model to give each patient a personalized predictive dosimetry. So how do we do that? We need information firstly from the IACT, which will tell us the artery-specific perfused liver volume. We then combine the information available from the technetium-99 MAA SPECT-CT, which will give us the tumor to normal liver ratio, or TNR. And putting that all together into the partition modeling, we will come up with a radiation plan for each artery that will infuse with Y90. So this is how the partition model works. This patient here has a large tumor in segment 4, supplied by 3 separate vascular territories, right, mid, and left hepatic arteries. We perform the intra-arterial CT angiography, which gives us volumetric information, and we draw the region of interest over these enhanced areas and transfer that information onto the MAA SPECT-CT. The MAA then will give us information about tumor uptake, normal liver uptake, and lung shunting. And putting all those information together, we will come up with a partition model where we split our injections into 3 different injections, because we know that For the same tumor as in the previous case, having been supplied by 3 different vascular territories, all 3 TNRs for each vessel will be different. So we believe that by doing that, we can optimize the amount of radiation we hit the tumors with and reduce the radiation to normal liver and lung. So we've also looked at our own results. What impact does IACT have on our SIRT coiling rates, safety and efficacy? This is actually going to be an oral presentation at RadiologyAsia on Saturday, and if you have time, I'll invite you to come along and have a listen. As I mentioned earlier, our prophylactic embolization rates are lower than that of the literature. That is also in line with our major complication rates, which are also below the recommended Society of Interventional Radiology thresholds. Our overall survival is also quite similar compared to the literature at about 13 months. We've also previously published some of our earlier results back in 2014, looking at about 100 patients who receive yttrium-90, and these group of patients are predominantly Hep B. You can look up the reference. Just to finish up, we've started doing some of our yttrium-90 cases via Transradial approach. It's still work in progress. At the moment, our workflow is to puncture the radial artery with the arm abducted. And subsequently, once you've inserted the sheath, we adduct the arm and rest the patient's arm on his or her thigh and proceed on as per normal. The reason for this is to minimize the amount of arm movement once the catheter is in the correct position and the patient has to go through the CT gantry. So in conclusion, I hope I've convinced you that AngioCT is an extremely useful tool for performing SIRT. It increases our confidence for planning as well as delivery of yttrium-90 with features such as the 3D roadmap and possibility of doing Transradial as well. It reduces the procedure time and increases the patient comfort. And overall, I think patients will benefit from having a safe and effective Y90. Thank you.